Welcome to Give to Gain, empowering women through knowledge and advocacy. I'm Gina Gaston-Ellie, and I'm representing the Missouri City chapter of the Links Incorporated in this special program to celebrate International Women's Month. We want to bring you information that we think will help you better navigate the health system, your pregnancy, and afterward. And so today we have with us two doctors who have spent, maybe almost 60 years together, all together in caring for women, and they're going to help educate us and give us tools for advocating for our own health when it comes to maternal health. So let me first start with you, Dr. Baker. Please tell us a little bit about your involvement in this issue and your expertise.
Absolutely, and thank you so much for having me here. I enjoy being part of this conversation anytime that I can. So I'm Dr. Kim Baker. I am a professor, I am a researcher, I am a mother, and I am an advocate. I've started this work in maternal health some 15 years ago, before I became a mother, and mostly on the reproductive justice end of things. Okay. Once I became a mother, it became very clear how much of the system was broken. And so much of my research geared towards maternal health for Black women.
Okay, and Dr. Burns, tell us a little bit about yourself.
I am an obstetrician gynecologist. I've been practicing pretty close to 30 years. In private practice first, then in public health. And now I'm an associate medical director for one of the managed care organizations for Medicaid. So my interest in this is from a public health perspective, but also because I've taken care of hundreds, it might even be at this point thousands of women, and I've seen, good care, I've seen bad care, and we're in trouble right now. Our numbers are bad, and they need to be better.
So we're going to talk about maternal health as it pertains to women, not only in the Houston community, in the country, but all throughout the diaspora, because we are looking at this as an international issue. But we do want to start with our community here, and we want to frame for people who are watching how bad of a problem it is. So in Harris County, which is where we're located here in Houston, Black women experience 3.5 times more fatalities in relationship to their pregnancies than do white women, for example. Tell us a little bit about Harris County and how bad it is and what this issue is.
Thank you for that statistic. It is dire, just as we said in the opening, right? And we compare Harris County to some of our numbers, and I know we're highlighting international awareness, right? We can compare these numbers to countries who are in developing situations, right? And so you think, and we talk a lot about the access. We're a stone's throw away from the largest medical center in the world.
World class.
World class. And so for us to have those numbers, it tells us a story about our community and the help that we need. And I wanted to share that because the first lesson I learned as a public health student was if you wanted to understand the health of a community, you look to the health of the woman, of the mother. And so maternal deaths as an outcome should be a huge signal for us to figure out what else is happening, right? Because that is just the glaring warning for us to dig deeper.
And sometimes it's not death. Sometimes it's not the death of the mother, I should say. Sometimes it's the death of the infant. Sometimes it's morbidity. Tell us a little bit more about the scope of the issue.
So the numbers are bad for Black women either way. The maternal death rate is higher, but the morbidity rate is also higher. So morbidity means bad things that happen during the pregnancy or the delivery or postpartum that have long-lasting consequences. So we're talking about strokes, we're talking about paralysis, we're talking about just a number of things that can go wrong but seem to go wrong more often for Black women.
I know a lot of people watching this are probably thinking, well, whose fault is it? Is it my fault? Is it the system's fault? So I want to explore that. But first, let's start with the beginning, which is a woman's health in general. Before she even thinks about trying to start a pregnancy, is our health? How are Black women doing in terms of their general health before pregnancy is an issue?
Such a good question. And we're kind of all over the place, but I think as you mentioned, when we want to talk about blood pressure and heart disease, like we already in our community have an issue just on our general health, obesity, all of these things. And I'm so glad you brought up the question, whose fault is this? Because this is a systemic issue, right? And so we don't want to point blame to our own community who needs a great deal of help, and understanding about how do we get here, right? And so for a woman who, before she even gets pregnant, we got to think about access. We got to think about if she has access to primary care, that is a doctor who listens and who cares, right? Who can catch these things early
Black
along.
Women often not have access to primary care doctors?
It is
in Houston, Texas.
It is very tough for quality care, and I know you can speak on that as a provider in your years, right?
Yeah, definitely. And I would say it goes back even earlier because statistics have shown that Black babies and Hispanic and Native American babies receive worse treatment in the nursery than white babies do. So it starts at the very beginning.
We're starting behind.
We're starting behind because we're not receiving the same care. And so it continues on as you get older, as a child, not having, obesity addressed, prediabetes. A child grows up to be an obese adult and has all of the morbidity that goes along with that, hypertension, diabetes, kidney disease, etc. So by the time you get to childbearing age, you're already behind the 8 ball. You started behind the 8 ball, but now you're really behind because you have all these health issues that haven't been adequately addressed and aren't being adequately treated.
Yeah, and I think I want to bring in the layer of shame that comes with that. Yeah. The shame that comes from these issues that we talk about. But then when the women in our community get of childbearing age, there's shame that comes with reproductive health in general, right? And things that, do we talk about this? Or how do I bring this up? Even if they're dealing with issues with fertility or planning, there's a huge gap in that phase, even within itself, before we can even get to talking about pregnancy.
I was going to add, when you're talking about, both of you talked about the issue of obesity, but when you think about things like grocery store deserts, food deserts, having access to healthy food in grocery stores that are easy to access, or having the time to get to a gym or the ability to afford a gym membership, these are things that often in our community are barriers to us being in optimal health, no matter our age or whether we plan on having children or not.
Absolutely. Yeah. There's one salient theme, though, here throughout this, and that's stress. And so
you mentioned mental health. The shame is mental health.
Absolutely. And so even when you're talking about from the babies in the neonatal unit, through adolescence, through childbearing age, there is the weathering hypothesis, right? That says that when we are faced with these circumstances and these systemic issues, the constant stress, it impacts us on a cellular level in our bodies, right? Physical, right? Physiological impacts. And so we really do see that come to bear with maternal health.
For example,
yes,
constant stress raises your cortisol levels. Cortisol is a stress hormone that normally fight or flight, it goes up, but it goes down quickly. But with chronic stress, it's always elevated. All the hormones are connected to each other, but cortisol is really connected to insulin. So that your insulin levels go up when your cortisol is elevated for a long period of time. When your insulin levels are elevated for such a long time, your body stops responding to insulin the way it's supposed to. Insulin also is one of those hormones that's supposed to come out when it's needed and then go away when it's not needed. But because your cortisol is elevated, your insulin levels are elevated, so now your cells don't respond to insulin properly. That creates situations like polycystic ovary syndrome, which causes infertility. But one of the hallmarks of PCOS is obesity. That whole circular pattern of chronic stress, elevated insulin, cells not responding, insulin resistance. It creates obesity.
And insulin resistance also is related to diabetes.
Yes, untreated, if it will become type 2 diabetes. Yeah. And so it affects your health in a variety of ways. And for sure, we need to address chronic stress, but as a minority person in this country, it's never ending. It's coming from all directions all the time. And saying you need to address it and actually being able to address it and lower it are two really different things. It requires constant vigilance. But even that is stressful, that you have to be thinking about that all the time.
Yeah. So when a woman gets to a point where she's thinking, I do want to get pregnant in the next year or two, what kinds of things would you offer to her that she consider?
So just kind of how we were saying about just checking to make sure you're at your most optimal health, right? To bring life into this world, which could heighten your stress because you're thinking about all the things
Which
like,
will heighten your stress.
right? What is
Kids
optimal
will heighten your
health,
stress.
right? And we always kind of make this joke like, are you ever ready to be a parent, right? Like, are you ever really fully prepared, right? And so when you think about that at a health level, just my own personal experience, finding an OB that I felt like I can trust, I was so afraid.
Yeah, I wanted to talk about that, about how does one go about finding a good doctor?
And so, you know, the one I had.
What'd you do?
So I kept the doctor I had when I wasn't thinking about being a mom. So it was the doctor I had for my reproductive health. And so I knew her, I was familiar with her. But once I wanted to get pregnant, decided that I was going to get pregnant, I felt like I didn't get the type of care that was necessary to transition into that role, right? It was just kind of like,
and you're a doctor, so I would think, I'm always thinking that the expert's going to get the best care because the other doctor is going to be
I had
responsive to you.
Absolutely. And in this case, I had, you know, we tell women to advocate for themselves, come with your questions, do these things, and I did that. That doctor did not like that at all.
Okay.
So it became very clear to me that I needed to find another provider. And I did. But a lot of women, you know, don't have time. Like, that creates more stress. Like, this is who my insurance covers.
A lot of women are also intimidated by doctors. So if the doctor comports themselves in a certain way, we default to the doctor's right and I'm off base, and so I need to back up. What is your advice, Dr. Burns, to people as they go about trying to find a doctor when they want to start a family?
It is a difficult task, you know, because a lot of it is personality driven. And you kind of have to know yourself as a patient, you know, whether you need to be your hand held and to really be walked through versus someone who will just give you facts and maybe not have the, you know, warm and fuzzy bedside manner. And some people don't know that until they actually get into the situation and realize, you know, what they need. I've never understood, you know, when patients tell me a doctor got angry because they wanted a second opinion or something like that. I'm like, get a second, a third, a fourth until you feel comfortable, you know, with whatever's being proposed. So, but there are physicians who take it personally, you know, if someone asks questions. But the asking questions is the only way, one, to know, but two, to be comfortable. So you have to advocate for yourself as a patient. You just have to.
Do you feel confident in a community like ours that if you have the time to keep searching, you can find someone you feel good about?
I do. I think so.
I think what I have been seeing, I think what's been helpful is just communities of women and networks, because we've raised this issue to the forefront. You know, you have more women being proactive and seeking out friends or, you know, colleagues. Who do you have? Who do you go to? Who do you trust? More than ever before. And that, I think that has been very helpful.
Are there other community health resources if you don't have access to a traditional medical environment or system, a healthcare provider? Are there community resources that you could access if you know that you are looking for someone to help guide you?
You mean like community clinics or?
I don't know.
Okay, like if you don't have insurance or
If you don't have insurance,
no.
I don't know what all resources are out
Yeah.
there.
So, for patients that don't have insurance or are underinsured, so they have a super high deductible, there are public health clinics in Houston, several actually. The largest FQHC, Federally Qualified Health Center in the state of Texas, is based here in Houston, and they have locations all around town. They have OB-GYNs, they have midwives, they have nurse practitioners. So they have a variety of specialists, maternal and women's healthcare specialists at their locations. They also have mental health services. And that becomes important because sometimes that becomes an issue before the pregnancy is over. And it becomes an even bigger issue afterward. Yeah. Right now, the number one cause of maternal death is mental health related. So postpartum depressions, suicide, or substance abuse. But back to the resources, that's there's one large one, but there's several smaller ones in the area in general, where that have maternal health, behavioral health, midwives, and a lot of patients will feel more comfortable with a midwife because their approach is a little more personable. They don't tend to have the large patient load, that a physician would have. So they have a little bit more time to spend to answer questions, et cetera. But it will take a little bit of research, but I think everybody should be able to find somebody competent and that they can be comfortable.
Yeah. And I think that's important too, because there's a distinction there. Like that's really good wraparound services for a pregnant woman, right? Especially in these federally qualified health centers. And what we also see is that for women who do have insurance, sometimes it's harder to get that level of referral and wraparound services. And so I know we talk about how this issue sees no class, right? It cuts across all socioeconomic statuses. And it's important to sit with that because when we do have women that go into the private sector and are seen by a private physician, sometimes they feel alone because they don't have, well, how do I find a midwife now? Or how do I find the mental health support that I need? Because it's not as easily accessible for them as it might be for this amazing model, right? Like if we could have that model for everyone, that would be ideal.
Okay, interesting. So once you're pregnant, you need support from, as you mentioned, so many different places. Doulas, what are the thought about doulas and their value, particularly for Black women in this community? I'll start with you.
I think they play a very important role. The problem is there's not enough of them. But the doula is a non-medical person, and they are designed to be your advocate. So to say things that you're afraid to say or that you may not know to say, to speak up for you in situations where you may not be getting the best care. So an example of that would be you as a pregnant woman, you don't feel well, and you go to the doctor and you say, I don't feel well, but you can't really put your finger on what is wrong. And so because you can't articulate it, it's not really taken seriously. A doula would be there to say, you know what, I've been with her the entire pregnancy and she looks different. Her face is swollen, her feet are swollen. I think something else is going on. And, to have somebody to advocate for you in that situation when you don't really know what to say. Same thing in labor. You're asking questions or you're wondering, should I get an epidural? Should I do this? Should I do that? And you're afraid to ask, or you ask and you didn't get the answer that you wanted. The doula is there to speak up and ask again and be a little more persistent if you can't do it, because you're in labor and there are other things going on. That's the role of a doula. And then they're there afterwards too, postpartum, to make sure everything is, going well and notice changes, should there be any, that you might not pick up on.
You have any other thoughts about resources while you're pregnant? Including, one of my thoughts was your partner. What should you be expecting from your partner? How can your partner prepare if you don't have a romantic partner? Can you recruit a partner? Do you suggest people do that? Because I know when I'm at the doctor, sometimes my mind is just frazzled.
Absolutely. And it's like all these things, I have my notes, but then you get in there and you're tired. Sometimes it just doesn't work out the way you planned. And so having a partner, having a friend, maybe a family member who's that person who's gonna be that person at the restaurant I always say that says, this food isn't right, send it back. Like that type of personality, right? Yeah. But in a very respectful way. I think it's very important. I just wanted to reiterate how important if you had the opportunity to get a doula, and I wish I did with both of my pregnancies, but with my second one, my sister kind of filled that role for me because she had the experience of a doula when she was pregnant. But I remember in my first pregnancy at the hospital laboring, and the nurse came in and said, do you want an epidural? And I remember thinking, I'm trying to follow my birth plan. I had all the things I'm supposed to be doing. I was like, could you give me 5 more minutes till I figure it out? She's like, you need to tell me now or it's not happening. And I just froze and I said, okay, I guess that's what I'm getting, right? And so just that when you brought that up, just how quickly it could happen when you have this plan and you have this thought about how it's going to go, but you don't, you freeze and you just kind of want to get through it with as less tension as possible. So I think doulas are so amazing for that. And I think our community is starting to kind of re-educate ourselves because we've had a lot of these recipes, prior to, so much of the modernization of our medicine. We had these people in our families who helped us through labor and postpartum, and that was their role. And so the bringing back of that, I think, is incredible.
Yeah. Mm-hmm. I know one of the big issues, and Dr. Burns, you kind of alluded to it, is just us not being heard. And we'll say whatever about how we're feeling, and it will be disregarded. And I know you have a personal story of someone you know who went through an experience where they tried to bring their health to the doctor's attention and were dismissed.
Yeah, unfortunately, it's a sad story. She woke up that morning with vague, I don't feel well, I'm going to call a doctor and see, and they worked her in, but 1, she did not see her physician, and 2, they did not have her chart. So this was before electronic medical records, and it was a very large clinic, and they had a complex system about how the charts were pulled for appointments, etc. So she saw one of the nurse practitioners, and her vital signs, everything looked normal. I think her blood pressure was something like 115/78 or something. That sounds great. But if they had had her chart, they would have realized that the entire pregnancy, her blood pressures had been 80/50, 90/60. So 115/78 was really high for her. And it met criteria for rule out preeclampsia. She should have been sent to the hospital, but because they didn't have her chart, they didn't know. And because when she got there, she couldn't exactly put her finger on what was wrong. She just said, I don't know, I don't feel good. She didn't have a headache. Nothing was hurting, So they said, oh, you're okay. You're at the end, everybody's uncomfortable at the end, blah, blah, blah. She went home. The next day, she still didn't feel well. So she told her husband, I'm not going to go to work today. I'm going to stay home. And she stayed home. And make a very long story short, her husband came home. He had been calling her all day, but he came home that evening and found her dead. So she had the autopsy showed that she had eclampsia, which is the most serious hypertensive emergency of pregnancy. She had eclampsia, she had a seizure, and died during the seizure. Had someone taken her seriously and just probed a little bit more, she could have even asked the question, is this your normal blood pressure? And that would have changed everything. She would say, no, that's a little high for me. And she said, "Oh, your blood pressure looks great, blah, blah, blah," and sent her out the door.
I think we're cliched as being so strong and so able to take pain. And I think we also, as women, and this is true for women of many cultures, we want to be what I call the too nice girl. You don't want to cause trouble. What would you say to women who are battling with both of those issues, the issue of being thought of as being strong and wanting to be so nice?
Oh, it's like I have to take my own advice because that's something that I've struggled with, right? Just culturally, wanting to toe the line, not upset anyone, not be confrontational, but at the same time act like nothing is wrong. I'm strong. And so I would just say, like, try to shake loose of that. Like I'm literally, as I sit here talking to that, telling myself this very thing. Like, as much as you can is a daily journey to shake loose of those things, to put yourself forward. We have to continue as women to put ourselves forward, because we see the statistics. And like, if we're not around to raise our kids, then what happens?
Is it fair to say sometimes it just is racism?
I think so.
We can talk about that all day.
I would say more that it's bias.
Okay.
That people have biases that they don't recognize. And we need culturally competent physicians and, providers in general.
What's a culturally competent physician?
It means somebody that is always curious, who's going to take the time to listen, and who's going to understand that their own personal experience is not the experience of everybody that they're taking care of. So they have to recognize that people are coming from different backgrounds with different experiences. And when they say something to you, it may not make sense to you because that's never been your experience, but because you need to have some curiosity and look into what they're saying a little bit more. And a lot of people just don't recognize when they hear bias, they hear prejudice, they hear racism, and so they back up and I'm not that. But everybody has biases. But you have to recognize them, and then you have to work to overcome them and make sure they don't interfere with you practicing good medicine. And so there are courses that teach cultural competence. I personally think it's something that people should do on a regular basis, every year, every other year, because it's so easy to forget the little things that you're taught during those courses, but it makes a big difference. But if everybody would just back up, be a little bit curious, and take the time, just the couple 10, 15 extra seconds to actually listen to what's being said instead of thinking about, I got to do this, I got to do that. The pressures on physicians are tremendous, especially if you work for somebody. They want you to see a certain number of patients every day, and all the charting, electronic medical records greatly slow down your ability to take notes. And so there's a lot of things that impede, what we want to do naturally. And so when you get in a room and somebody starts asking a bunch of questions, the thought is not, let me listen to them. It's like, oh, you're going to put me behind, And cultural competence teaches you to not do that and to stop and listen to what's being said, and don't assume because this person is Black, Hispanic, whatever they are, that what they're saying has no value.
And if I can just add to that, a very important piece, this part of what I also like to add to humility. Like it is a lifelong journey. And so some people can think that they can maybe take a course or like check off a box and say,
then I'm done, I'm cured, I'm good.
And that's why I said it needs to be
I'm
done.
enlightened.
It needs to be done yearly.
You will continuously be confronted with your own biases. We will, just as we struggle with shedding kind of like stereotypes or things that we go through that have been instilled with us. This is a daily practice. And so for providers and for everyone, right? Like it never stops. Yeah. It never ends. So that's why it's a huge step towards humility to accept that you'll always need to stay curious and, provide the best care possible.
So if you're pregnant, your relationship with your doctor is not going in a way that you feel good about the doctor, what do you do?
I got another doctor. I was, and I was, I guess I will say I was scared because I was well into my second trimester. Like,
Well, you were the perfect person to ask this question to.
listen, approaching my third trimester, and I'm like, no one's gonna. I remember thinking in the back of my mind, no one's gonna take me. Whoever I end up with, the doctor's gonna be like, "What's wrong with her coming to me this late?" Something like that, like the judgment that kind of I felt. And I just had to shed it because I was listening to these stories, and I kid you not, this was 2017. Luckily, I was pulled into a research project that was a citywide kind of let's figure out what's happening with maternal health while I was pregnant looking for an OB, right? And it was my job to bring women together and ask questions, focus groups. Luckily, I was able to meet an OB who was part of that work, and I went up to her after a community talk and was like, look, I'm looking for a doctor. I had a situation with my other one. Are you taking patients, please? And she said, absolutely. Now, I know that's not everybody's story and they can't be so but it is a example of how just to advocate. Like, I just kind of threw everything, to caution to the wind and said, I'm going to go up to this OB after this community meeting at the YWCA and ask if she could be my doctor. And that's what it took.
Being a parent requires you to sometimes to do things you wouldn't have otherwise done. And it's maybe the first step in that. Absolutely. As a mom, that you have to just go, this is what's best for my child, so that's what I'm going to do.
Absolutely.
Well, I can tell the opposite story.
Okay.
And it didn't happen often, but it happened to me before. I had a patient that every time she would come to her visits, she was just unpleasant to my staff. To the point where when my staff would see her name on the thing, like, oh, Miss So-and-so's coming today, because she was so rude to everybody. And, when I would go into the room and try to engage her, she really wouldn't. And one day, listening to my staff complain about seeing her name on the thing, I said, you know what, I'm going to have to talk to her today. And so that particular day, she came with her husband. And I went in and I just said, you know what? Let's talk. I said, because you're clearly not happy here. And I don't, there's nothing wrong with you. There's nothing wrong with me. It just happens sometimes. There's personality issues. I said, but this is your first pregnancy. This is too important. You need to be happy. You should be coming in here like my other patients. What did I measure today? Blah, 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 da, 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 da. Asking lots of questions. I said, you don't do any of that. And I said, so, you're pretty far along in your pregnancy. You're going to have trouble getting somebody to take you, but I will help you find somebody because it's too important, your first pregnancy especially, for you to come in here and just be so obviously unhappy.
You were really good at a breakup.
And
I know, right?
That was a great breakup speech. But you're right. Everyone should feel good.
Yeah. And she said, you're right. I should have said something a while ago. And I said, it's okay. I said, we'll find you somebody. We'll get you taken care of. And we did. Yeah. But, it was, like I said, it had gotten to the point where my entire office would see her name and be like, oh.
And that's not good for her, too. Yeah, it's not good for anybody. So we now move into after birth. So we assume that the problems have been solved during birth. You've got your partner coached up. If you wanted a doula, you found a doula. If you needed support services, mental health services, you got through that. You go through childbirth. And then we have problems not just with women surviving it, but infants. And the numbers for Black infants surviving birth are abysmal as well. Can you give us more insight on that, Dr. Baker?
So just infant mortality in general. It is an issue that it boggles my mind that we're still faced with, right? I think we do, and we're seeing kind of new initiatives where we can place nurses or social workers with women in the home, like once after they've given birth, just for that additional help. Like if a doula is not available and they may have a little bit more training. So we've seen programs that can have better outcomes with infant health when you
So
do
a lot of the
that.
problem is not enough support at home?
A lot enough.
Okay.
Yes, because even if you think about, I think when you were going through the list of all the things in the back of my mind, I was thinking about, I wish families would like gather together and like, instead of giving money for these baby showers, like give money for postpartum doula support or other types of support or care that we don't necessarily think about. Like we think about these other things, but we don't think about like what the mom needs.
Right.
We think, and the baby for that matter, in that
And
aspect.
some of that might go back to the whole cultural shame too of not discussing it.
Yes, absolutely.
I don't know.
Absolutely.
Yeah. Well,
absolutely.
a lot of women are ashamed because they get home and they really don't know what to do. And they feel like, once they have the baby, some switch should flip on and they should know how to care for their baby, how to care for themselves, all of that. And they don't know, but they're too embarrassed to ask. And so there really should be some sort of support system just to follow up. Other countries, will have midwives or social workers, come to the house on a regular basis, twice a week, 3 times a week. Breastfeeding consultants to come and make sure that that's going well, because that's a huge source of frustration, especially at the beginning. But the follow-up that we completely and totally do not have in this country, but other countries have recognized the importance of it, and
Kick
they
you
have
out of the hospital fast too.
Yeah.
In this country.
Well, absolutely.
I did find some numbers. 11.6 out of every 1,000 babies in Harris County die. Nationally, for Black women, it's 5.4. So more than twice as often in our community. Yes.
And again, a lot of those babies are born to moms who had issues during the pregnancy. So the mom was a gestational diabetic who was not compliant with her diet. And so babies born to moms with gestational diabetes have hypertrophy of their heart. So their heart is much larger than it should be. And because it's bigger than it's supposed to be, the muscle doesn't squeeze as well. Those babies are also born with a lot of fat right here in the center, and their shoulders are wider than babies that are born to people without gestational diabetes. So there could be birth trauma. They could have a shoulder dystocia, or they had a C-section. The mom had a C-section because the baby was so much larger than it should have been. And then mom's at home, with the incision, and mom's obese. She's diabetic still. It's resolving, but still. And so she doesn't heal as well, and then the wound's coming apart. And so there's a whole bunch of things that happen because mom's health wasn't optimal that affects the baby.
So what do you want moms to do, and what do you want us to do as the friend, sister, mother, perhaps, of a new mom? What's both of our jobs? What can we do?
No, I think the care and support. I think the care and support is showing up and
Do a sign up genius.
absolutely
So
sign
everybody
up
take a
genius,
shift.
right? Take a shift to
Yeah.
wash clothes, wash dishes, like do just the labor in the home when you come home. And we tell moms, sleep when the baby sleeps, but that never happens. Like I don't know who came up with that phrase, but like we need to abolish it and say no, she won't be able to do that because she's doing X, Y, and Z. Come over and do those things for her so she can get rest. Or not just to come over and play with the baby, right? And so it's those things I think that we have to be a little bit more prescriptive of in postpartum that we haven't always been for a variety of reasons.
I hate to keep kind of putting pressure on the new mom to do something, but I feel like I hope there is something she can do. And I know that's hard when you might be depressed and you're
Yes.
exhausted, but is there something that you think that's not terribly difficult that could be a first step?
Don't ignore things.
Okay.
Don't assume it's part of the postpartum. If you don't feel well, call your doctor. If you have a headache that won't go away with the pain medicine they gave you to go home with, call your doctor. If you're getting up, doing things, but you feel short of breath, winded, call the doctor. People get home and they don't want to leave the baby. They're afraid if they call, something's wrong, they'll make them go back to the hospital. They don't want to do that. There are so many reasons why people do not follow up on symptoms that really should be followed up on. And a lot of what happens in the postpartum period that's bad is because they had symptoms, but they ignored it.
I've heard you say before that when people don't feel well and they don't know exactly what it is that feels wrong,
To me, that's always
That's
a
a
warning
cue.
signal.
Yeah.
Because my experience is that my pregnant patient could always tell me what's wrong. Oh, I'm just so tired. Oh, I'm hot all the time. My back is killing me. Well,
Yeah.
that sort of thing. But when they're there and it's vague and they can't, that would always set off warning bells for me.
So we have a lot of women in our community in Texas and certainly throughout the country that are immigrants, Black women from Nigeria, from Africa, from wherever, and they face even more challenges, I believe, because you've got a different culture. Can you talk a little bit about what they face and how they might better navigate the health system?
Yeah, good question. And I think it's a mix. I think it's a spectrum because we also do see a paradox. And so what we call sometimes the immigrant paradox. And so, migrants or immigrants come into this country, even giving birth, sometimes have better health outcomes because you have to think about, and we said this in the beginning, like the role stress plays. And so they haven't been steeped in a culture of oppression here in the United States, as so many of Black women. And so they're coming, this is the land where I've been wanting to get to. And so there are resources for me. How do I get them? How do I build a network? How do I build community? And they're doing those things when they can, right? For sure, there are migrant women who are coming here and their language barriers, or they may not have family, or they haven't established a community yet, however. But the fact that we have so many FQHCs and these connected care places for women who may not have those resources, those are super accessible. And so finding them may be difficult because of language barriers, but there are resources for those women.
Do you have thoughts on that, Dr. Burns?
When I was working at the large FQHC, the majority of my patients were immigrants from all over the world. And I would say the most common problems I saw was probably diabetes. But once they get into the system, their access, continued. We would set up appointments for them the entire pregnancy so that was never going to be an issue. The clinic was also open on Saturdays. And so, a lot of people, especially with transportation issues, the husband was working, they would come in on Saturdays for their prenatal appointments. So, that particular system that I'm referring to went out of their way to be accessible to everybody. We had translators, Spanish, Vietnamese, on site, and then we had the translation lines that were readily available for whatever language. The clinic that I worked at in Southwest Houston sat right in the middle of a large Hispanic area, but there was a huge population from Afghanistan there. And so we would have interpreters speaking Dari or Pashto, depending on what part of Afghanistan they came from, readily accessible because we needed it. So that there are FQHCs all over the town and in the surrounding communities. There's a very large one down in the southern part of our region, so that serves Brazoria all the way down. The north doesn't have quite as much, although one of these FQHCs is starting to expand that way. So they're doing all they can to sort of broaden access for people in general, but our pregnant ladies especially, there's an OB-GYN or a midwife at every location.
Okay. Throughout other areas of the world, whether there is a relatively good maternal health system or a poor one, it appears as though, well, the data shows that Black women fare the worst in every society, whether it's because of access to care or whether it's because of quality to care. We tend to take the brunt of both of those things. What is your thought about that phenomenon, that happens all over the world for us, that that's what we're facing?
I know. I think about it as like the global South, because we talk about like how just here in Southern United States, we have our disparities that we face. But if we think about it as the global South, we can make that comparison easily. We can think about colonialism and extraction of resources and how women's bodies have been used for labor, right, unsupported for decades. And this is the outcome. Like, these communities have been stripped of their resources and their power. And so that is what we're seeing. Even now, I think, recently in terms of like the stoppage of a lot of international support going to these countries for community health and women's health, like, this is worsening what was already a huge problem. And so, I shudder to think about kind of what the next few years, the next 5-10 years will look like for women and girls.
When the fallout really hits.
Yes.
Right.
Yes.
So, Dr. Burns, you had a tip that you try and tell your patients when they're going through their pregnancy?
Yes, I would always tell them to buy a little notebook and keep it with them, or they could use the app on their phone, Notes app, but anytime a question came to them, just write it down, because inevitably what happens, they come to their appointment and they can't remember what they wanted to ask. But if they're writing it down, then when they get there, they have the list of questions, things that are important to them, and make sure they get the answers they need.
Well, we appreciate both of you sharing your personal anecdotes and experiences, and appreciate you sharing the knowledge that comes from looking in the faces of so many women in their most really vulnerable season when you're pregnant, you're facing a pregnancy and you're hoping for a good outcome. And we hope that those of you watching this, that we've given you something that has helped you gain more tools for how to advocate for yourself so that you might have optimal health, not just during pregnancy, not just after pregnancy, but we pray all of the time.